Hey guys, we're going to be talking about lower airway disorders now. I've got a list that was in the book, the bronchitis, asthma, flu, pneumonia, all of TB, all of those things. So I've got those listed on the slide for you guys. Now, let's talk about acute bronchitis for a moment. Of course, you guys can tell by the base word and the root word that it is inflammation of the bronchi and the bronchioles. And of course, this can be exposure to any irritant. Most of the time it's tobacco smoke with a lot of patients. It just becomes, and a lot of them, it becomes a chronic bronchitis thing. So anyway, what happens with these patients is they have, just the inflammatory process. Then they have vasodilation, and then they get congested, and then that mucosa is swells up, and then they can have bronchospasms. Now, this affects the airways, not the alveoli. These patients have a large amount of mucus, and they have that cough that will not go away. Sometimes it's that barking cough. It's just really, really an irritating cough, 5 to 20 days. And some patients, it even, will move on into the chronic bronchitis as well. We want to treat their symptoms. We typically diagnose them through their history and physical. Of course, a lot of people do a chest x-ray just to make sure that there's no pneumonia in there. So that's one of those things that a lot of them do. Now, this is the most common condition that a primary care physician is going to treat. It's more common in kids and older adults. Of course, they're at higher risk for all of these things. So with all of these illnesses, so of course they're going to be in this category. And of course, this is, again, I said, it's typically a short-lived thing. Most people are sick a week to 10 days or so, but it is self-limiting. If you've got a patient that has a heart issue or lung issue or cystic fibrosis or smokers, then of course we typically move into that chronic bronchitis. They usually have it a lot longer than just our normal everyday healthy person. Now, usually bronchitis is viral, but it can be bacterial. Now, when somebody coughs up a big loogie and says, "Oh, look, it's green," that doesn't necessarily mean that it's bacterial. The look of the sputum doesn't determine whether it's viral or bacterial. Now, typically, we've gotten away from giving antibiotics, and we've gotten away from giving cough suppressants with acute bronchitis. It's not in evidence-based practice these days. A humidifier is a great thing. A cool mist humidifier is the best thing that you can do. I always tell my patients, if they've got especially sick kids, if they're having an asthma attack or they're having a coughing spell, bundle them up and take them outside in that cold air. It will help with the coughing. Now, I wanted you guys to see. While I'm thinking about it, if you guys are using a humidifier, put a piece of plastic or an old shower curtain down. Well, not too old if it's moldy, like a lot of people's. I know. I'm not going to say anything. We all have sometimes where we don't keep our shower curtains as clean as we should. So I'm getting off my soapbox and telling on myself right now. So anyway, we want to put that down to protect the floor. If you've got carpet, that moisture in the carpet. It obviously bad on wood floors, but we can grow some fungus among us if we've got a lot of humidity in our flooring. So just be careful about that. Now, we want patients to increase their fluid intake. We want them to take in 2 to 3 liters a day, right, with a lot of these lung things that have a lot of mucus involved with them, because we want those secretions thin. We want that mucus thin so that they can get it out. Of course, we want them to avoid irritants, like if they're a smoker, we want them to not smoke. Of course, you know how well that goes. And then, good hand washing is key with all of these inflammatory processes. We want to wash those hands good so that we're not carrying bacteria and viruses to other people and, catching it ourselves. So anyway, like I talked about, if it can go on to the chronic, and if we get that chronic inflammation, then the mucus glands get bigger and they secrete more mucus, and so that's why chronic bronchitis, they have a lot more issues. So those bronchial walls just really thicken, and of course, if they thicken, then what's happening? that airway's getting smaller. So we really have to worry about the amount of airflow that's going through there. And of course, gas exchange is always an issue because we have mucus plugs and infections and narrowing airways. So just keep that in mind. Now, asthma, I'm not going to talk a whole lot about because I know that Ms. Candler always covers that. Of course, you guys know that asthma is just a series of, you get that airflow obstruction and the bronchia are just hyper responsive, and then that airway inflammation goes on. So patients are usually wheezing. Some of them have a chest tightness. It's not chest pain. They describe it more of as chest tightness. They have a cough, and sometimes it wakes them up at night. They may have a productive cough, with your asthmatics. Of course, long-term asthmatics, their symptoms are a little bit different, and of course, the older we get, but typically they don't have, but they may have some mucus, usually yellow from those eosinophils in there. So asthma is it a breathing in issue, getting air in issue, or getting air out issue? It's a getting air out issue. The air goes in and we can't push. We have to push it out. So anyway, it's prolonged expiration. Patients are using those accessory muscles. A lot of times they can't talk. They cannot get out a full sentence and breathe at the same time. So they may breathe in, say one word, breathe in, say another word. So anyway, PFTs are really helpful with asthma, with a lot of these lung conditions, because they help diagnose. It helps see how severe the obstruction is and see how well the treatment's working. Now, of course, this is, when we think of asthma, we think of it as being a childhood disease, and 75% of cases are diagnosed before age of 7. A lot of kids will have that remission period through puberty and then start in again when they're adults. So asthma we've greatly improved it with our different medications and, staying on top of the treatment regimen, because what we're trying to do is decrease that chronic inflammation, because, as we get older, that chronic inflammation can really be a problem for us. And so we try to keep it down so that these kids that have asthma can be fairly healthy adults and not have lung problems. Now, most of the time, asthma symptoms are reversible most of the time, but of course, asthma can kill people as well. There are about 4,000 deaths a year from it. Now, what we're doing is we're checking the patient's daytime symptoms, and we're checking the nighttime symptoms. We want to know how much it wakes them up, that cough, how many times it wakes them up at night. We want to know how often they're using their short-acting inhalers. If they are going through an inhaler in 10 days, Houston, we have a problem, and we may have to put them on a different, medication. They may just be on the short-acting if they're just starting out with their asthma symptoms, and it may be that, we have to put them on something other than just a rescue inhaler. Of course, we want to know how well they handle exercise, because that's a big issue with asthmatics. A lot of times they will play basketball and get short of breath and have to use their inhaler and things like that. So we want to see how well their asthma is working out with their exercise, and if they're able to perform their ADLs. Depression can also be an issue, and we want to see how they perceive their asthma. Our goal with asthmatics is to improve their quality of life, and of course with asthma it's the same thing. Stay away from those triggers. That's what we can do best for our patients. Now, influenza. Now, of course, a lot of people go to the doctor and they come back and they say, I've got the flu. If somebody has a viral infection, they automatically say, oh, yeah, I've got the flu. But that's usually not the case. Usually patients will have those like severe muscle aches, that fever, chills. They're tired. Their head just feels like it's going to explode, like their freight train's going through it. They're really weak. Some patients have a sore throat. Some have a cough. Anorexia, they really don't feel like eating. Of course, we advise everybody to get their flu vaccine. It is... It doesn't protect you from everything, but what they do is every season the CDC goes and decides what the most prevalent, they check worldwide and see what the most prevalent viruses are. and they make up the vaccine with the top ones. So if you get, of course, another kind of flu, and you say, oh, I got the flu and I got my flu shot, I'm never getting this thing again. It just is that you got a type of flu that wasn't covered in the flu vaccine. So just keep that in mind. Now, of course, are really young, are really old, are healthcare workers. There's some people that are at a higher risk for the flu, and so of course we want our medical staff vaccinated because they're going to be caring for all these patients, and if they come down with it, then we don't have anybody to care for the sick people. So that's the reason why healthcare workers are so important. Now, the flu vaccine is only effective really for about 3 months, and the flu season is 5 to 6 months. So sometimes patients, especially our COPDers, our heart patients, they may be getting, and healthcare workers, may be getting 2 shots. So anyway, sometimes it lasts longer than usual, so maybe that all of us need an extra shot. Now, I do want to say that antivirals are something that. You know what? Before I get into that, I do want to say if you there are some different considerations for the flu vaccine, and I forgot to say that if you are allergic to eggs. That's one of those things you can't have the flu vaccine. Kids with asthma or reactive airway, those kids cannot have the live attenuant, like the nasal spray. They have to have the shot. There's some different considerations. Pregnant people, it's still advised, but some pregnant people don't want to get it. If you've got a weakened immune system, you definitely don't want the live attenuated. So there's some considerations, and I forgot to mention that. So I just wanted to throw that in there. Now, also, if you have taken an antiviral medication for the flu within the past 48 hours, you can't get a flu shot. So I just wanted to throw that in there. Now, let me get back to the antivirals. They can be effective. You have to give them right off the get-go. If you don't give them within the first 1 or 2 days of getting sick, they don't work very well. They're typically very expensive. So that's something to consider. The old drugs that we used to use, we don't use them much anymore. And the antivirals are end in vir, V-I-R. So think about that. We can't cure the virus. So there's no cure for the influenza, for the flu. Hand washing is the best thing that we can do. I mean, that is the best thing that we can do. If everybody practices good hand washing and they watch out, because it's spread by droplets, they're sneezing in their arm instead of, in their hand and wiping it all over everything, if we're not around people that are, really sensitive, that are really ill, then we can keep the flu spread down. Now, typically the incubation period is 18 to 72 hours, and it typically lasts for 5 to 7 days. Now, kids, it does last longer in them, so that's something to keep in mind. Usually their lungs are clear, right, because it's not an issue with that. And typically a rapid flu test is what we do to diagnose these patients. Of course, it's symptomatic treatment. Now, pneumonia, of course, that's an excess of fluid in the lungs. That just comes on from the inflammatory process. So either they've inhaled an irritant, or they have come in contact with some organism that's infectious and they have gotten pneumonia from it. Now, of course, you can get it from the community, or you can get it from the hospital, which is a nosocomial infection. So those are all things to think of. Now, of course, usually the patient is not breathing up to par, and they've got all this gunk in their lungs instead of oxygen going in there. So we've got to check their oxygen level and things along those lines. Now, there's some diagnostic tests listed on page 42. I wanted you guys to look at that. Now, I wanted you guys to think about this. We don't wait to start treating them. If we do a sputum culture and try to figure out what's going on with them, we do not wait on that culture result before we start them on antibiotics. We're going to start them on something along those lines of what we think that it is, what type we think it is, and we're going to go from there because they can get seriously sick. Now, I really I have some in my notes on the PowerPoint. I have some extra Sorry, I'm trying to switch over to this slide. I've got some extra notes in there for you guys about the process. I'm not really going to talk a whole lot about it. Now, I wanted you guys to see, now we've got some, different masks and some different, I've got low flow and I've got high flow oxygen delivery systems on here for you guys that I just wanted to show you guys in case you haven't really been in a hospital a lot so that you could see those. Now, we're going to move on and talk about fungal infections. Of course, the different types of fungal infections depend on where you are. Now, there are certain areas. Now, North America, Japan, Scandinavia is a big one, and they have higher rates of these fungal infections. Now, sometimes they're opportunistic and sometimes they're primary. It just depends. Now, we can inhale or ingest these spores. And, of course, our weakened immune system, it depends on, if our immune system's up to par, typically, we can get rid of things and fight them, our body will. But, of course, if we've got AIDS, typically we'll see histoplasmosis or pneumocystis gyrovici. It used to be pneumocystis carni, and I have tried so hard to get in the habit of saying pneumocystis gyrovici. So I did it. Yay, go me. But anyway, now 60% of these patients are asymptomatic. Usually we diagnose it by culture, stains, biopsy. We need to check the histology on that. I have seen typically, we think of this certain patient that gets this fungal infection, but I've seen a lot of cases in younger people. I've seen a lot of cases in younger people that have traveled. So, travel history is really important with these patients. I have had several people that have gone to California that have wound up with histoplasmosis. They go in, they do a chest x-ray, they see all these nodules, and they're like, oh my gosh, they've got lung cancer. And it winds up being a fungal infection. So, really think about where your patients have been and what they've been exposed to. A really good history is really important for these patients. Now, amphotericin B is a treatment for this. It's given IV, and it's really, really a nasty drug. It's very toxic. There's a lot of side effects with it, kidney toxicity, fevers, chills, nausea, vomiting, really hard on the veins. So you've really got to watch that IV site for thrombophlebitis and, just make sure that it's okay. Our azoles, our fluconazole, our ketoconazole, sorry, I got my tongue twisted in there. Those are some other typical treatments that are used. Usually treatment is for about 4 to 12 weeks. Now, with these drugs, sometimes because of the side effects, we can pre-medicate the patient with steroids or NSAIDs or antihistamines, and they tolerate it a little bit better. But we definitely want to push fluids, obviously, because of the kidney toxicity problems. Now, TB, of course, you guys know that this is highly communicable. Now, TB killed over 2 billion people in the 1900s. See what a big problem it was? We have more drugs now than we used to. We just had, one drug, and so patients would become resistant to that really easy. And so now, we've got the rifampin and the isoniazid, and so we've got some. We're adding to our repertoire, so it's helping with that, and we know more about it, and so we're able to. Use good practices and things along those lines. Now, of course, you guys know that it's caused by the Mycobacterium tuberculosis, and it is transmitted by aerosolization. So that those droplet nuclei, when patients cough or sneeze or, like me, you know how I am, I've got those overproductive salivary glands. It's always, say it, don't spray it. I wanted the news, not the weather with me. So anyway, I'm a big spitter. You guys see me do it all the time. I'm like, try to cover it up, but I know y'all have noticed me do it. So, aerosol it is really something that you have to watch it with. So you definitely want to do the good hand washing. You definitely want patients to cough into their sleeve instead of into their hand and wiping it everywhere. Now, we had TB under control quite a bit, and then HIV pops up, and we get an increased rate. So we've got more coming up because we've got these, these autoimmune disorders. They're more common in those patients because, you see on these commercials, I'm trying to remember which drug it was, but I saw a drug that's used for, Crohn's and things along those lines. And it says, notify your family care physician if you have any night sweats or coughs or things along those lines. And because all of these things do knock out our immune system, we do have to worry about getting TB. So that's the reason why we do TB skin tests or a chest x-ray, either one, before we give a lot of these new biologic meds, because we want to make sure that the patient doesn't have TB. We're going to get a baseline, and then we're going to keep a follow-up on that. Now, with these patients, you see a cough, fever, that's night sweats. Some of them may be coughing up blood. They're tired. They lose weight. Some of them have a chest pain. Sometimes it's because of the cough, and sometimes it's just a chest pain. Shortness of breath. Irregular menses is another one. We can do a chest x-ray. We can do a TB skin test, the acid-fast bacillus. But really what we want to do is, we want to confirm the diagnosis. We want to get a sputum culture to make sure and confirm that. Of course, if we do that TB skin test and we get greater than 10 millimeters on there, that's they've been exposed to it. It doesn't mean that they have an active TB. They have been exposed to it at some point, and it may be dormant, because it does get in there and it gets in the lungs, and they wall themselves off in these little nodules, and you can see them on chest x-ray, and it is just dormant in there until, of course, our immune system is compromised, or as we age, which our immune system is compromised then. But then the TB will come out of latent phase again, and it can come, full-fledged TB again. Now, what you have to make sure is that the patient is taking their meds. If they do not take their medications, obviously we've got to worry about it coming back or not being killed off. But the main thing is that we have so many that are drug resistant. So we really have to make sure. And the patients are on these drugs for a long time. At least 6 months. Used to, they were on it for a year, 2 years, 3 years. But these new drugs have helped us cut it down to 6 months. So they have to take the drugs, period. Now, these medicines do cause a lot of side effects. Nausea is a big one, so the patients may be needing some antiemetics, some Phenergan or some Compazine or, something along those lines. So just keep that in mind, that it does cause a lot of nausea. Also, these drugs are terrible on the liver. So if you have a patient that is a big drinker, if they're an alcoholic, AA, anything to stop them drinking. Now, airborne precautions is something that we do in the hospital, because obviously we have weakened and sick patients in the hospital, and we need to be very careful with them. Our hospital room, it's a negative pressure room. So what happens is it has its own air conditioning system, own ventilation system. It vents to the outside. Of course, if you've got somebody that's sick, that's coughing all the time, and we've got this small room, we've got a really big concentration of the droplet nuclei in there, right? So if we vent it to the outside, it spreads out, so there's less chance of exposure. And we have this negative pressure room. So when somebody opens that door, normally when you open a door, all that air comes out and hits you in the face. And that's not what we want, because, of course, some of that can get out to the people that are outside. So that negative pressure room sucks it back in whenever they open the door. So that's the reason why it's really important. Now, of course, we're going to be using our masks, right? We're going to have our special fitted masks. We want at least above a 95 on those. We definitely want to protect our people that are going in. Now, they're going to be in isolation until they have 3 negative sputum cultures. Now, a lot of times patients, there's a lot of patients that have latent TB that, live with their family, haven't had an issue with it. And a lot of times those patients' families are going to be positive to TB because they have been exposed to it. They may not have had, a full-blown TB, but they've been exposed to it. So you really have to do a lot of education with your patients. Got to take your medicine, got to carry it with you, because, if something happens and you have car trouble and you have to spend the night overnight, you don't want to miss any doses. So they've got to know the side effects, all these things that we've talked about. Now, they need to know that after they take the drugs, about 2 or 3 weeks, they're no longer contagious. Now, just because they're not contagious doesn't mean that they don't have TB and it's still an issue. They still have to take their medicine for their 6 months or whatever it happens to be. Now, some places will do, if you've got a patient that doesn't hear, they will do the DOT. They will actually watch these patients take their medicine. Some home health agencies will go in and watch them, and it's not even with those. It's just they're trying to find ways to, just get successful treatment. We want fewer drug relapses. We want a lot less drug resistance. So these are some ways that they've come up with to actually try to do that. Now, nutrition is key. You remember that I talked about how they've got weight loss and fatigue and things along those lines. Now, nutrition is really important because, we want to heal this infection. So remember, nutrition comes into play with this. Now, they're going to be doing a lot of frequent follow-ups for at least a year with TB. That's, important for them to know as well, that they're going to be going to the doctor more frequently. Now, a lung abscess, now that is just... we've got bacteria in there, and so as the bacteria grow and go through their life cycle, you get that liquefaction, necrosis in there, and so you just get this nice big fat lung abscess. And so a lot of patients will have a pleuritic chest pain. It hurts more when they breathe. It's just I don't know if any of you guys have had pleurisy. I've had it, and it is not fun at all. They'll have fever and night sweats and cough and see all these things. What does it sound like? I mean, we're worried about TB, right? That's the first thing that pops into everybody's mind when they hear these things. Now, they may have some purulent sputum. Half of the patients, when they get that sputum up, it is putrid. You'll know it if you smell it. Now, empyema, that is pus. A third of the patients that have a lung abscess will have empyema. Now, of course, antibiotics, clindamycin is what we really like to use. May drain that abscess, may have to take that lobe out and do a lobectomy. It just depends on how well the antibiotics work, and sometimes if you drain it, it'll come back. So anyway, so we definitely want to have a good history. We want to know if they've had pneumonia, if they've aspirated, if they've got GERD, if those stomach contents are coming up, and we can definitely swallow that back down and get a lung abscess from that. A tumor can be an issue. Of course, any immunosuppressed patients, they've got a bigger chance of having a lung abscess. Seizure disorders, swallowing disorders, because a lot of times, we're talking about regurgitating and things along those lines. So we can definitely aspirate from those things. Now, we also have, our mouth is gross. Anybody with a nasty mouth, if they've got periodontal disease, gingivitis, things along those lines, they're at a higher risk for a lung abscess because, a lot of times we suck down in our lungs what's in our mouth. So think about that. IV drug use is another one. I just wanted you guys to think about some of the causes. Now, of course, when we've got somebody with a lung abscess, when we listen to them, we may hear some crackles. Of course, when we do percussion, it's going to be dull, right? Because is air dull? No. Stuff is dull, whether it be fluid or pus or whatever it is. You'll have a dullness when you do percussion. Of course, chest X-ray, CT might be needed. They can aspirate that culture. They can do a transtracheal approach. Of course, we can get a sputum and do a gram stain. Really, what we need to do is wash our hands, get our flu vaccine, get our pneumococcal or pneumovax, whatever you want to call it. We definitely want to get that vaccine, and we definitely want to avoid smoking as much as possible. Now, we're going to talk about the interstitial lung diseases. Now, the interstitium is the area between the alveoli and the capillaries. So that is where our gas exchange occurs, right? So it can be damage from exposure. It can be disease, inflammation, injury. There's a chart on a 27-7 I want you guys to look at. But the lungs have undergone this injury. They're trying to heal themselves, but what happens is that, they will a lot of different things, and I'll talk about that more in each individual one. But usually what happens, these patients have impaired gas exchange, right? Because we're on, our upper airways move air. They don't exchange gas. So these interstitial lung diseases are between the alveoli and the capillaries, and that's where gas exchange occurs, and that is impaired. So that's what I want you guys to be thinking about as far as nursing diagnosis as we talk. Now, they're progressively going to get worse and worse and worse. They're progressively going to get short of breath. As the disease progresses. Corticosteroids is the biggest thing. I mean, these patients are going to be on long-term corticosteroids, so they're going to have those lovely bruises on their arms because they have thinner skin, all of those things. So corticosteroids is a big one. Sometimes they're on immunosuppressants and cytotoxic agents as well. Most of them are on oxygen at some point, but really there's nothing you can do for it besides lung transplantation. So, just think about that. We're going to talk, and this is a slow process. It's not an overnight thing. It takes years to occur. We're going to talk about restrictive diseases, that lung tissue gets thick and we can't get the gas exchange and the lungs get stiff and don't expand. We're going to, we're going to talk COPD and all those things as we go here. Now, idiopathic pulmonary fibrosis, it's a restrictive lung disease, and it's pretty common. And I've always called it pulmonary fibrosis, but this book terms it idiopathic pulmonary fibrosis, so I guess we'll call it that as well. Usually these patients, of course, weight loss, fatigue, non-productive cough, that irritation, they're just coughing, shortness of breath on exertion. The body is trying to repair itself, but it goes way beyond that. It's excessive wound healing is exactly what it is. You get that excessive wound healing, and you get that fibrosis, that fibrotic changes, and then it scars. And so are we getting air through scarred alveoli? And no, it's not. So, of course, corticosteroids and immunosuppressants, of course, a lot of risk factors with these. Smoke, and it can be firefighters. It doesn't have to be cigarette smoking. Metal dust, farming dust, hairdressing chemicals, all of those things can cause pulmonary fibrosis. There's about 30,000 new cases a year, and typically patients only live for about 3 to 5 years. So, the lifespan is pretty short on that. Usually they get an infection that they can't get rid of, or they'll go into full-blown respiratory failure or heart failure, and so these patients typically don't live very long. Now, 2/3 of the cases are diagnosed after the age of 60, but the age ranges from 40 to 70 on pulmonary fibrosis. We don't find it early on. We find it when it's advanced because it's a progressive disease. So usually it's too late to do a whole lot for it. Anyway, it's a sad deal. Now, typically we're hearing inspiratory crackles. Patients usually having some difficulty breathing. They may be leaned forward, trying to, they've got that air hunger. We may see them using that pursed lip breathing, which we need to teach them if they don't know how to do it. All of those things, think about with the pulmonary fibrosis and the COPDs and stuff. We definitely want them to get their immunizations. They are extremely... their lungs are crappy, and we have to worry about them getting the flu and pneumonia and it killing them. So we definitely need them to get their immunizations. We also need to promote nutrition as well. And of course, these patients may be put on the lung transplant list. Now, sarcoidosis, these are just granulomas, and now it affects other places, but we're talking about the pulmonary system, so the lungs are where mostly you see the sarcoidosis. Now, 30 to 60% of patients are asymptomatic, and they just happen to be, having surgery, and they do a chest x-ray, and they're like, oh, holy cow. What are those on that chest x-ray? Of course, history and physical may give you some clues to it. Of course, may have to do a biopsy for confirmation. Now, sarcoidosis typically resolves within a 2-year period, but some patients it doesn't. Our T lymphocytes usually come in there, and what happens is they're normally protective, but we get a bump up in them, and they damage the lung tissue. Corticosteroids are the treatment for this. That's just one of those things that you just, with all these lung diseases, corticosteroids are the big thing. And of course, there's just so many side effects, so patients typically aren't happy being on all these steroids. But it's just the way it goes. So obviously we're going to be watching blood sugars and all those things, skin changes, give it with food, all the things that we've talked about all along. Now, these patients may have fever, night sweats, they're tired, weight loss, dry cough, wheezing, shortness of breath. See, all of these things really common things that you're going to see in all of them. Okay, the pneumoconiosis, those are the occupational interstitial lung diseases like silicosis in the coal workers, or asbestosis, all those things. All these different people with different occupations inhale whatever it happens to be, silica dust or coal or asbestos, and they can wind up with interstitial lung disease. But now with the asbestosis, they can wind up with the mesothelioma, lung cancer, laryngeal cancer. Most of these things are asymptomatic for several years, 10 to 30 years with a lot of them. And then, boom, they found out they've got issues. Typically, when we're assessing these patients, we're listening for abnormal lung sounds. We're checking their pulse ox, their respiratory rate and effort. We're looking for weight loss. We're looking in how are they doing their ADLs now. Geez, I can't walk 10 feet across the room anymore. I get really short of breath. We're checking those cough characteristics, seeing if they're coughing up anything, because, we're looking for other things when we see this. We're going to make sure it's not pneumonia. We're going to make sure, we're trying to figure out what's wrong with them. So that's the reason why we need to know the characteristic of their cough and their sputum. Now, again, this is a process that comes over several years, and so a lot of times they're going to have the fingers clubbing. They may have some lymphadenopathy. They may have an enlarged spleen or liver. And, of course, as we progress, that cardiac output is going to be decreased. Now, if you look on page 760, you're going to see some nursing diagnosis. Now, these patients, they've gone on for all this time with this. Do you think that they're going to get well? No. Most of the time, the care is palliative. So, we're going to try to make them as comfortable as possible. We're going to try to keep them going and as independent for as long as we can. And, of course, we're going to be working with a lot of different people to try to make sure that happens. Now, COPD. With COPD, that is emphysema and chronic bronchitis. It's an umbrella of those two things. Patients have bronchospasms and shortness of breath. Now, when we're talking about COPD, we're talking about a huge number of patients with COPD. 52 million people worldwide, 16 million in the U.S. So a lot of patients have COPD. So you're going to be seeing this a lot. Now with this, their lung elasticity is crappy. Their lungs are hyperinflated. There's a picture in your book, and I don't have it here with me right now, but that diaphragm is flat. So, we're not able to push out oxygen like we normally would. So those lungs are hyperinflated. So those patients are struggling to, you hear that. Sorry, I have to make my noises. But they're trying to push out oxygen, not get it in. They have a feeling of air hunger. They're having to work harder. They have an increased demand, so their metabolism is going to be up. That's why they lose weight, typically. Their increased work of breathing, so sometimes they're using those accessory muscles. A lot of times they have a chronic respiratory acidosis as well. So, those alveolar sacs just aren't as elastic, and so some collapse, or they narrow, or they overstretch, or whatever, but we're not getting good oxygen exchange is what's happening with these patients. Now, with chronic bronchitis, we talked a little bit about that earlier, so I'm really not going to go into that. I put a slide on here showing you guys, what COPD looks like. I've got the bronchioles and the alveolar ducts in there so that you guys can see a picture of it. But as you guys see, it looks like, a wad of grapes in there. Now, I want you guys to always be thinking about your nursing diagnoses and, the ineffective breathing pattern, ineffective airway clearance. They get the mucus down there and they can't get it up. Imbalanced nutrition, they're not eating what they normally did, and they're breathing harder, so their metabolism jumps up because they're trying to, they're trying to breathe. So imbalanced nutrition, a lot of times these patients look really frail. I just want you guys to think along those lines. Now, the inhaled drugs for COPD are pretty much the same as they are for asthma. Patients really need to know how to use an inhaler correctly, and I know that you guys already know that, so I'm not going to go into that. Obviously, we want them to rinse the mouth. They're on these chronically. So we definitely have patients with COPD that have a lot more fungal infections in their mouth. So now, I did put on this slide under some breathing techniques, the diaphragmatic or the abdominal breathing. You can teach your patient how to do that. You can teach them how to do the pursed lip breathing. All of those things are really good. We want to conserve as much energy as we can. So, planning our day is really important. These patients get really winded really easy, so we definitely want to make sure that we have their if they've got all these things to do and they want to take a shower in the morning, we may have to put that off because sometimes it's just all they can do to eat breakfast in the morning. So we definitely want to eat in small frequent meals. We can use the bronchodilator 30 minutes before meals to help open those airways up so they breathe a little bit better. Of course, we want high calorie, high protein diet. It's really important with these patients. Milk and milk products, that they have always said that causes the mucus production to increase and it to become thicker. So with these patients, we definitely want to push fluids. Water is always a good thing. And we want them to maintain as much as they can, as long as they can. So, activity is always good. Of course, these patients are going to typically have supplemental oxygen therapy as well. Now let's talk a little bit about cystic fibrosis. Now that's a genetic disease, and there's exocrine glands. Those exocrine glands produce mucus and sweat and tears and digestive juices. They don't work right. So cystic fibrosis affects the respiratory and GI systems more so than anything. This is the most common fatal recessive disease in Caucasians. Most patients now they didn't live past childhood. They are starting to live a little bit longer. I mean, we have a lot of patients with cystic fibrosis that are still alive in their 30s, but it is still a fatal disease. It is a terrible disease. Patients have this cough. They get this thick mucus that they cannot get out. You have to do chest physiotherapy on these patients before they can even eat because it's so thick that they can't breathe and eat at the same time. Their lungs are hyperinflated. They have a lot of infections. It's constant. So hygiene is really important. Don't let kids with the flu come over and visit these kids. So weight loss, shortness of breath, their breathing rate is really high. There is a lot of, these kids may have 4, 6, 7 inhalers and breathing treatments. It's constant. These families that take care of these kids with cystic fibrosis, it is a full-time job. Most of them quit their job just to take care of their patients. Now, this is diagnosed by a sweat test. Now, we're checking the chloride in the sweat. We have to have 2 positives for a diagnosis because it's not really a foolproof test. Genetic testing is something, and my phone's ringing, so I'm going to pause this.